The NeoMono trial is a phase 2 neoadjuvant randomized clinical trial including triple-negative breast cancer patients, male and female, with an ER and PR below 10%, and HER2-negative, so with a softer definition of eTNBC like than many other trials. Patients were included if they had tumors bigger than 10 millimeters, with or without nodal invasion. So the population was broader than in most other ICI trials, and patients were treated with a neoadjuvant chemotherapy combined with atezolizumab, a PD-L1 inhibitor, in the control arm, and in the study arm, patients received a 2-week immune therapy window before the start of the chemo and immune therapy. The special thing about that trial is, although it recruited 3 years ago, we had no chemotherapy arm as a control arm, because we considered ICI therapy as a standard at that time, we planned to recruit 458 patients. We had to stop recruitment after the first interim analysis due to protocol mandated reasons. And we had already then at that time point included almost 350 patients, and patients stayed on therapy because it was clear that we wouldn't meet the primary endpoint. And the primary endpoint would have been a superiority of the window, that was not the case. We reported these results last year in San Antonio. And this year we were, although just to mention that, we had the highest PCR rates ever reported in triple-negative breast cancer, going up to 91% in the study arm for the PD-L1 positive population. And the interesting thing about the analysis that we are presenting here this year, 2 analyses we are presenting, is the sensitivity analysis regarding the biomarker PD-L1 measured on immune cells in the tumor environment, with more than 1% being positive. PD-L1 IC, we had this year analyzed the high-risk population, somehow matching the Keynote 522 population with the high-risk patients, tumors bigger than 2 centimeters, all with nodal involvement. The theory was that maybe in the high-risk population, this effect of PD-L1 would be lost due to the higher risk of the patients, but that was not the case. It was still the high PCR rates of 88% in the study arm for the PD-L1 positive patients and 80% in the control arm. Still, again, no treatment interaction, but a signal that PD-L1 is an important marker. Of course, we cannot conclude that it's a predictor for ICI therapy or for atezolizumab, because we had no chemotherapy control arm, but it's a strong signal that it's an important biomarker. And on the other hand, we also reported here or are reporting here the low-risk analysis, which includes only patients with tumors smaller than 2 centimeters and no nodal involvement. And with 108 patients, this is the biggest low-risk population ever reported in an ICI neoadjuvant trial. And in that subset analysis, in the PD-L1 positive patients, we could report 100% PCR rate in PD-L1 positive patients in the study arm and 90% in the control arm. Again, the highest PCR rates ever reported. That was not the case in the PD-L1 negative patients. In those patients, the PCR rates were around 50 to 58%, still very high, but not as high as in the PD-L1 positive population.